OMM lymphatics techniques for URI or HEENT infections. Thoracic inlet release. The patient can be either seated or supine for this technique. The physician places his or her hands on the shoulders with thumbs on posterior first rib region and index finger and third digits on the superior and inferior to the clavicle and at the sternoclavicular joints bilaterally. The physician monitors motions of the tissues superiorly and inferiorly, left and right circumferential motion, and translation left and right. Contact direct or indirect barriers and hold for 20 to 60 seconds. This technique is useful overall for opening up the lymphatic duct where most of the body's lymph drains into the left subclavian vein into the heart. Suboccipital diaphragm OA release. This technique is useful for chronic headaches for migraines, tension headaches, and chronic sinusitis. The patient is positioned supine and physician is seated at the head of the table. Physician contacts the suboccipital tissues of the patient underneath the occipital shelf with the pads of the fingers. Use the weight of the head of the patient to provide anterior force on the tissues. You may add lateral force by externally rotating wrists and cephalotraction of occiput by curling fingers towards your body. Hold for 30 seconds or until tissues release. Submandibular release. The patient lies supine and the physician sits at the head of the table. The physician places the second, third, and fourth fingertips immediately below the inferior rim of the mandible. The fingers contact superiorly into the submandibular fascia to determine if fascial restrictions are present. The physician then imparts a direct or indirect vectored force until meeting the bind direct or ease indirect barrier. The force may be applied very gently to moderately. The physician continues until a release or fascial creep is palpated and follows this creep until it does not reoccur. This may take 30 seconds to 2 minutes. The physician takes care to avoid too much pressure over any enlarged and painful submandibular lymph nodes. Frontal temporomandibular maxillary sinus effleurage. The patient lies supine and the physician sits at the head of the table. The physician places the index fingertips, may include third fingers, immediately above and medial to the eyebrows. The physician's fingers begin a slow, gentle stroking or effleurage laterally that takes them immediately parallel to the suborbital ridge until they meet the area of the pterion. The fingers continue inferiorly in a continuous gentle motion towards the temporomandibular joint and inferiorly over the mandible. The physician places the index fingertip pads, which may include the third fingers, just inferior to the infraorbital foramina. The physician's fingers begin a slow, gentle stroking or effleurage over the patient's skin immediately parallel to the lateral aspect of the nose until they meet the dental ridge of the gums. This is repeated for 30 seconds to 2 minutes. Alternating nasal pressure technique. The patient lies supine and the physician sits at the head of the table. The physician uses an index finger to press on a diagonal into the junction of the nasal and frontal bones, first in one direction and then the other. This procedure is applied for 30 seconds to 2 minutes. Alternate methods based on personal modifications of hand position are acceptable. Auricular drainage. The patient lies supine with the head turned slightly towards the physician, and the physician sits at the patient's side near the head of the table. The physician stabilizes the patient's head by placing the cephalad hand beneath the head to elevate it slightly. The physician places the caudate hand flat against the side of the head, with fingers pointing cephalad and the ear between the fourth and third fingers. The physician's caudate hand makes clockwise and counterclockwise circular motions, moving the skin and fascia over the surface of the skull. There should be no sliding over the skin and no friction. This procedure is applied for 30 seconds to 2 minutes. Galbreath Technique. The patient lies supine with the head turned slightly towards the physician, and the physician sits at the patient's side near the head of the table. The physician stabilizes the patient's head by placing the cephalad hand beneath the head to elevate it slightly. The physician places the caudate hand with the third, fourth, and fifth fingertips along the posterior ramus of the mandible and the hypothenar eminence along the body of the mandible. The patient opens the mouth slightly. The physician's caudate hand presses on the mandible so as to draw it slightly forward at the TMJ and gently towards the midline. This procedure is applied and released in a slow rhythmic fashion for 30 seconds to 2 minutes. It may be repeated on the other side. Cervical chain drainage. The patient lies supine and the physician sits at the patient's side near the head of the table. Physician stabilizes the patient's head by placing the cephalad hand beneath the head to elevate it slightly, or by gently grasping the forehead. The physician's caudate hand, or palmar aspect of the fingers, makes broad contact over the sternocleidomastoid muscle near the angle of the mandible. From cephalad to caudate, the fingers roll along the muscle in a milking fashion. The hand may be moved slightly more caudate along the muscle, repeating the rolling motion, going cephalad to caudate. This same procedure is applied both anterior to and posterior to the SCM muscle to affect both the anterior and posterior lymphatic chains. As a caution, do not perform directly over painful, indurated lymph nodes. Trigeminal Stimulation Technique. The patient lies supine and the physician sits at the head of the table. The physician palpates along the superior orbital ridge, identifying the supraorbital foramen. The physician places the pads of the index and middle fingers just inferior to the orbital ridge and produces a circular motion with the fingers of both hands. The physician palpates along the inferior orbital ridge, identifying the infraorbital foramen. The physician places the pads of the index and middle fingers just inferior to the infraorbital foramen and produces a circular motion with the fingers of both hands. The physician palpates along the mandible, knowing that the three foramina form a straight line identifying the mandibular foramen. The physician places the pads of the index and middle fingers over the mandibular branch of the trigeminal nerve and produces a circular motion with the fingers of both hands. This trigeminal stimulation procedure is applied for 30 seconds to 2 minutes at each of the 3 locations. OMM techniques for head and neck disorders. OA release. The patient should be in the supine position for this technique. The physician places his or her hand under the occiput, wraps the fingers around the occipital bone, and in contact with the trapezius muscle. A cephalad traction is applied to the occiput to remove restriction on the vagus nerve. Use enough pressure to disengage the OA joint to allow for free motion of the occipital bone. This pressure should be applied for 30 to 60 seconds to allow enough time for the tissues to release. This technique can be utilized in headaches, temporomandibular joint dysfunction, post-concussive syndrome, and other disorders of the head and neck. Since the vagus nerve is the parasympathetic innervation for many organs, this technique is very useful for a large variety of disorders aside from those of the head and neck. The patient's head should then be returned to neutral and motion at the OA joint reassessed. Cervical soft tissue technique. The patient should be in the supine position for this technique. The physician can perform this technique by sitting at the head of the table or by standing next to the patient's head. Both ways are demonstrated here. The finger pads are in contact with the cervical paravertebral musculature. The physician draws the musculature gently in an anterior direction to relieve any restriction in the musculature. If any area has some restriction, more focus can be directed at that spot. This technique may be performed in a rhythmic and kneading fashion or in a sustained manner. As the treatment is performed, tissue tension is reevaluated to assess the effectiveness of the technique. This technique should be continued for approximately 30 to 60 seconds or until the tissues have been released. This technique can then be reassessed by assessing the motion at the levels of the cervical spine. This technique can be used for the treatment of neck pain, migraines, tension headaches, and many other disorders of the head and neck. Thoracic myofascial release. The patient should be in the prone position for this technique. The physician places their hands on the thoracic paravertebral muscles on both sides of the spine. Then pressure is applied to contact the level of the fascia. Motion is then assessed in the cephalad-caudate direction, side bending, and rotation. This technique can then be performed directly or indirectly. If the indirect approach is chosen, the fascia is taken into all three planes of motion in the position of ease. If the direct approach is chosen, the tissue is taken into the barrier of the three planes of motion. This patient prefers cephalad side bending to the right and rotation to the right. The direct approach is taken in this case, so the tissues are taken into the caudad, left side bending, and left rotation. The position is then held for 30 to 60 seconds until a release is palpated. Once the motion has ceased, the fascia is assessed in three planes of motion. This technique can be used for patients with head and neck disorders to release restrictions in the fascia of the thoracic spine. Thoracic muscle energy. The patient is in the seated position. The physician places their thenar eminence of the rotational side of the patient's dysfunction over the rotated segments. This patient's upper thoracics are neutral, side bent left, and rotated right. To treat this patient's somatic dysfunction, the patient is placed in neutral and the segments are side bent right, rotated left into their barrier of motion. The patient is then instructed to try and return to neutral against the physician's counterforce. The contraction is held for 3 to 5 seconds and the patient is instructed to relax. Then the patient is taken further into the barrier of the rotational and side bending component, taking advantage of the refractory period that occurs after the patient's contraction. This cycle of contraction and relaxation is repeated 3 to 5 times, and then the physician provides a final stretch into the patient's barrier after the final relaxation. The patient is then returned to neutral and motion at the dysfunctional segment is reassessed. CV4 Technique. The patient is lying supine with the physician at the head of the table. The physician crosses or interlaces the fingers of both hands and cradles the patient's head with the inion between the physician's thumbs. The physician then assesses the patient's cranial rhythmic impulse or CRI. The physician encourages extension and resists flexion with each impulse. The force is maintained as the CRI decreases until a point is reached, at which time there is no impulse. The CRI will then resume. As this happens, the physician remains in the position and awaits the impulse to return to its normal flow of 8 to 14 cycles per minute. The motions of the patient's cranial bones are then reassessed with the vault hold. This treatment can be used for headaches, whiplash injuries, vertical, tinnitus, TMJ dysfunction, and many other head and neck disorders. Direct inhibition of the lateral pterygoid muscles. The patient is in the supine position with the physician at the head of the table. The physician contacts the lateral pterygoid muscles just anterior to the temporomandibular joint bilaterally. Continuous pressure is applied to the muscle to initiate the feedback loop to the brain. This direct stimulation will signal the brain to stop firing the pterygoid muscles and relax them. This pressure should be held for approximately 60 seconds. This treatment is reassessed by palpating the lateral pterygoids for tissue texture changes. The treatment can be used for temporomandibular joint dysfunction, headaches, post-concussive syndrome, and many other disorders of the head and neck.